Can you see the second lecture, small intestine 2?
Yes.
Okay. So in continuation with the previous lecture, we will see in this lecture now how the absorption of different elements are taking place. The major elements, how carbohydrates are absorbed, how proteins are absorbed, how fats and electrolytes are absorbed, how vitamins are absorbed in the small intestine, and what is the how calcium is absorbed and how iron is also absorbed and according to the body's need. We will see it here in this lecture. As I told you in the previous lecture that it is all the absorption is taking place earlier part, that is duodenum and jejunum. Last part is mainly for vitamin B12 and bile salts. So 50% of the small intestine can be removed if there is a problem, not unnecessarily, but with if there is a tumor or you can say blockage, that time it can be surgically removed. Except for the last 1/3 or last part where vitamin B12 and bile salts are absorbed, you have to think about if you remove that, then the person may have deficiency of vitamin B12 or indigestion of the fat. So to understand the absorption, you must know the anatomy. That, as I told you, that there is a larger surface area is present in the small intestine, although the small intestine is a very lengthy organ. But still, if you unfold it, you will find that inside it is folded, mucosa is folded. If you again go in deeper, you will find that it has got villi, and then villi also has epithelial cells, and epithelial cell will have microvilli. So it is increasing the surface area tremendously. If you look at the arrangement of the cells, suppose this is a villus. This is one villus, and over here the epithelial cells are located. Here is the second villus, and here are the epithelial cells located. Over the epithelial cells, there are fibers which are microvilli, and they are making the brush border like this. This area, which is the crypt, uh, you can say these are the two mountains. The area between these two mountains here is the crypt. It is known as the crypt, and the cells here are the baby cells, the one which is just forming, and the older ones are on at the top. So as they grow older, they will move up. As they grow older, it will move up. And there is one more tendency that all the cells will be removed or replaced within 3 days. In 3 days, the whole of the mucosa will be renewed. And these two cells are the two adjacent cell, this cell and this cell. There is a tight junction here. There is a tight junction here. So whatever you want to absorb, you have to that thing has to pass from the luminal surface. Let me explain it here. This is a tube, and this is the lumen inside, and these are the cells. So here is a tight junction. So the element has to pass from the lumen into the cell, and from the cell into the interstitium, and from the interstitium into the blood vessel capillary. So these are the steps of absorption. These are the steps of absorption. So for every villus, there is a specific structure is there. So this is a villus, one villus. It has got a capillary network here, and in the center, in the center there is a one blinded vessel, which is known as lymphatic vessel, branch of lymphatic vessel, lectial. Branch of lymphatic vessel, which is known as lectial. So this is capillary, and this one is lectial. It is a part of the lymphatic vessel. A terminal lymphatic vessel is present, which is known as central lacteal within the core. I will tell you what is the use of this lacteal. So let me go directly to the picture, then you will understand. So if you see this, these are the folds. Circular folds are found. On these circular folds, we have got a, again, villus. If you magnify this villus, it will become like this. This is the villus which contain the epithelial cells. On the epithelial cells, you have got, these are the brush borders. These are the brush borders. This area is known as crypt of Lieberkühn, and the baby cells are present here. The older cells are present here. And in the center core of the villus contains the capillary network, plus the yellow color is the central lacteals, lymphatics. Okay, so how the absorption take place? Absorption of different elements take place by a different mechanism. What are these mechanism of absorption? Give me example of mechanism of absorption. Absorption example. How the absorption take place? You have finished urinary system also. No idea? How the absorption take place? Examples. Either it will be absorbed actively or what?
Inactive. Passive.
Passive, not inactive.
Yeah, need a transporter.
Okay, active can be primary active or secondary active, or any other L. Primary active transport, secondary active transport, and what other types of transport? Tertiary active transport. Primary, secondary, or tertiary. What is the, give me example of primary active transport. No idea. You are in which level now? No idea about the example of primary active transport. Have you heard about sodium potassium pump?
Potassium pump.
So what is that example? Is it an example of which type of transport? Suppose this is a, yeah.
Primary.
So why it takes long time for giving me the example? Suppose this is a lumen and this is epithelial cells. So sodium is present here. Chloride is there, water is there, glucose is there. When you eat food, all these elements are there. And these are the epithelial cells. They have to absorb and send it to the capillary. This is the capillary or blood vessel. You can remember, just it is going into the blood. So how it will be absorbed? It will be absorbed due to either passive transport or due to active transport. When we say active transport, it is passing through the secondary active transport because the primary active transport is taking place here. Sodium potassium pump. Sodium potassium ATPase pump is there. What is the function of sodium potassium ATPase pump? What is the action of sodium potassium pump? It is present at basolateral membrane. What it will do? It will
transport sodium
where to where?
From the inside of the cell to the outside.
So sodium will move out.
Yes.
And
potassium will go in.
One potassium will go in, one sodium will come out, right?
Yes.
Is it?
No, I think it's 2 sodium or 2 potassium. I'm not sure.
2 potassium, 3 sodium, because you know sodium potassium means what? Sodium potassium means life. If sodium potassium stop functioning, person will be dead. So if you don't remember this, then you will not pass. You have to remember it, that what is the function of sodium potassium pump. Sodium potassium pump is always throwing 3 sodium out in exchange with 2 potassium inside. Because of that, less sodium will be here, and because of that, more sodium can enter into the cell. At this time, the carrier protein, which is doing this, it can be sodium and chloride come together, or it can be sodium or glucose come in together, like that. Sodium glucose transporter, symporter, sodium chloride transporter, or sodium hydrogen antiporter. Antiport means sodium will move in and hydrogen will move out. This is called as sodium hydrogen antiport, opposite direction. Okay, so how sodium is moved in? Sodium moves in by a transport, by a protein, by a channel. Suppose this is a epithelial cells and here is the lumen. Okay, and here is the SGLT, that is sodium glucose transporter, SGLT pump or carrier protein here. So it will move sodium inside and glucose inside. This is the function of SGLT. So sodium, which was here in the lumen, glucose, which is there in the lumen after digestion, it will come inside the epithelial cells and then leave the cell. Now, glucose will move out of the cell by a transporter protein. We call it as GLUT, or it is specifically known as GLUT2. GLUT2 is the carrier protein present here. So sodium glucose transporter will make the glucose inside, and from here glucose will move out into the interstitial space by the GLUT2 transporter, and then it will go to the capillaries in the blood. Okay, this is how it will be absorbed. But what about fructose? How the fructose is absorbed? If it is there is a glucose, there may be fructose also. For fructose, not the same procedure. The procedure is from the lumen into the epithelial cells by GLUT5, GLUT number 5, and from the epithelial cells to the interstitial space by GLUT number 2. Same pump. Okay, I will show you here in the diagram. So this is the lumen here, yellow color fluid is there, and this one is the epithelial cells. These are the brush border. Over here, the carrier proteins are there. So sodium is moving in, glucose is or galactose is moving in by SGLT, by sodium glucose transporter. Once they are inside, then glucose will leave and go to the interstitial space and then to the blood vessel by the GLUT2 transporter, by GLUT2 transporter. Similarly for fructose, fructose will be absorbed by GLUT5 transporter and then it will leave the cell by GLUT2 transporter. Now you may be asking why to remember all these things? Why to remember SGLT? Just remember glucose is transported like that. Because can anyone guess why I am telling you all these details? Why you have to remember SGLT, GLUT2, GLUT5? Why you have to remember? You can remember only the process, but why
Yeah,
specific? Hmm.
maybe any deficiency in these SGLT or anything congenital can affect it.
Maybe, very good. It can be a genetic disorder which is abnormal SGLT, so glucose cannot be absorbed. Very good, excellent. More common, more than this.
Diabetic patient, no.
In pharmacology, when you go to pharmac lecture, they will tell you that how the blood glucose level is regulated by modifying the action of SGLT. modifying the action of GLUT5, modifying the action of GLUT2. That's why. And what are the effects of drugs on these to regulate the glucose absorption, sodium absorption, fructose absorption, all these. These are the drugs are made to on the basis of these transporter. They can modify the action of this. Maybe they can make more SGLT so that more glucose will be easily absorbed instead of going into the feces, right? How proteins are absorbed? Very interesting protein. I will show you picture directly. So proteins are absorbed in the form of either amino acid or small peptides. Now, previous few slides before I asked you about active transport. How many types of active transport?
3.
Primary
Secondary and tertiary.
and tertiary. Primary means when? What is the primary means? Primary active transport means can you show me in this picture where is the primary active transport is happening in this picture, whole picture? Is there any place where primary active transport is taking place?
Interstitial fluid and the cell. Sodium, potassium, ATPase pump.
Very good. Why you said this is primary?
Because it doesn't need any transporter.
Eh? It needs transporter. Why? It is the area where
because it's not
ATPs are directly used. Here in this transporter protein, ATPs are directly utilized here. ATP broken down to ADP and energy. So it is required for movement of the sodium and potassium. This is primary because ATPs are used on the same place, same cell, same carrier. Okay. Okay. Tell me where is the secondary active transport is happening? In this picture, all three things are there. Primary, secondary, and tertiary. Where? No idea.
Is it the amino acids and sodium?
Yes, it is the amino acid and
secondary.
sodium because it is not using energy directly here. What it is using? It is using the effect of this
Electric
pump.
reaction.
Yeah, this is sodium is moved out. So less sodium here and more sodium here. This will make the sodium moving inside very easily. So this pump, which is sodium amino acid transporter, it is function only when sodium, not alone sodium, but it has to combine with amino acid. Then only both will be moving in. If only one is there, it will not function. This is secondary active transport. Now tell me where is tertiary active transport is happening?
Hydrogen and small peptides.
Okay, how? Hydrogen and the hydrogen is used at two places. Sodium hydrogen also and hydrogen peptide also. Where is the tertiary?
Is it with the small peptides?
Yes, see here. This is primary, number one. Because of this, less sodium is inside. So number two is this one, where sodium moves in and hydrogen is moving out because of less sodium here. Okay. So this is called as secondary. Now, because hydrogen is out now and there is no hydrogen inside, so hydrogen will can come now. This is now hydrogen will come and this pump is only function when hydrogen plus small peptides bind. And that's why the hydrogen and as well as small peptide will come inside. This is tertiary. First step is this, second step is this, third step is this. That's why it is called as tertiary active transport. So primary amino acids are absorbed by tertiary active transport After that, it will leave the space or leave the cell and go into the interstitial space and join the capillary blood. This is how it is absorbed. How about fat absorption? Which carrier proteins are required for fat absorption? Is it primary, secondary, tertiary, or what? Guess what is the answer? Is it primary? Is it secondary? Is it tertiary? Or is it another?
Maybe secondary.
Why? See, this is a cell, epithelial cells. This is a cell wall. Okay. Cell wall is made up of what? Made by what? Cell wall.
Oh, the heads and tails. The
Lipid bilayer. So fat is a lipid and this is a lipid. It can come easily. No need. Okay. So fats does not require any carrier protein. They are fats. They will just merge with the wall and they can come easily inside. So they are carried in the form of micelles. I will show you here in the diagram. Monoglyceride and fatty acid are coming in the form of along with the micelles. This is here is the micelle. It's the smallest form. Once they come here, they will leave. This is formed because of the bile salts. So once they come near to the cell, they will leave the bile salt and my monoglyceride diffuse, fatty acid will diffuse inside and they will join here inside the cell to form the triglyceride. After triglyceride, adding the lipoprotein to it, it will make a chylomicron, which is a big amount. This is a protein combined with lipid. So it will become chylomicron coming from the endoplasmic reticulum. Then this chylomicron will diffuse out of the cell by exocytosis. And where it will go? It will go to the capillary or where? It is going to the central lacteal. Yeah, it is a lymphatic. It will move into the lymph. Fat will go to the lymph. Central lacteal will go where? From here, where it will go? Lymphatic to? Remember the anatomy also. Thoracic. What is the next? Hmm. Where it will go lymphatics? Where the lymphatics drain? No answer? Thoracic duct. Where the thoracic duct will open? You don't know anatomy? It will open into the vein. Which vein? Just go and search. Thoracic duct will open where? Hmm? Where?
IVC.
No,
Portal.
no. Go and search where the thoracic duct will open and it will throw all the lymph, all the fat into there, and then it will go off from there to the liver after that, after circulation. This is a homework.
Doctor,
Yes.
subclavian.
Subclavian vein. Good, good, good. Did you Google it? Okay, coming to the iron absorption. Iron absorption takes place, specific form of iron is absorbed. Only ferrous form or heme form can be absorbed, not ferric form or other form cannot be absorbed. And it requires different energy dependent carriers. It also require carrier mediated transport. And from there it will be given to the blood in the form of ferroportin. It will leave the cell and then it will enter into the blood. So iron absorption is controlled by hepcidin. Have you heard about this term, hepcidin?
Yes, on him.
Where? It is controlling iron absorption. So where you heard this hepcidin? In which
Him immune.
subject? Heme immune?
Yeah,
Where
and
in
here
him?
previously you told us about it.
Yeah, in the last lecture, liver. Liver synthesizes hepcidin. Okay. So hepcidin is controlling the iron absorption. In the blood, iron is carried in the form along with bound to the plasma protein transferrin. So ferrous iron, or you can say just the iron combined with transferrin protein, and then it will be plasma protein and transferrin, and it will be circulated. If the dietary iron is not needed at that moment, if suppose iron is absorbed and it is not needed, then it will be stored as ferritin. So ferritin is a stored form of iron, stored form. And if you remember, this iron will be stored here in the epithelial cells. And as I told you, this epithelial cells will remain only for 3 days. Whole of the mucosa can be replaced in 3 days. So if they are not used, then it will be sloughed and go into the feces. Will be lost into the feces. Here it is. So dietary iron in the form of heme or ferrous iron with the help of a specific protein, heme carrier protein or divalent material transporter, it will come into the cell. Into the cell, if it is not required, not needed at that moment, it will be stored as ferritin. If it is required for the blood to synthesize these things, then through the ferroportin, it will be transported back into the interstitium and then into the blood. So hepcidin is working here. Hepcidin is acting on ferroportin. It is inhibiting it. It is inhibiting the ferroportin, inhibiting. That means if more iron is absorbed or if body does not need, then hepcidin level will be high and it will stop iron moving from the cell into the blood. Hepcidin is actually controlling iron absorption by inhibiting the ferroportin. Calcium and vitamin absorption. Calcium enter the luminal membrane of the small intestine epithelial cells by use of electrochemical gradient. Positivity outside, negativity inside, then positive calcium can move inside. Calcium will exit the basolateral membrane by a specific pump, which is known as calcium ATPase pump. Suppose this is a cell, this is a lumen. Then calcium will move in, and then calcium will move out by calcium ATPase pump, and then go to the blood. Okay. Its absorption will be increased or enhanced by vitamin D. So always calcium preferably is given in the combination with vitamin D3 combination so that its absorption will be increased. Other vitamins are absorbed because they are water soluble, so they will be absorbed passively with the water. Fat soluble vitamins are absorbed along with the micelle. Just like fat, how it is absorbed, it will be absorbed fat soluble vitamin. Whereas one more important one is the vitamin B12. It is absorbed only when it is combined with intrinsic factor in the terminal part of the ileum through endocytosis. That means a molecule will be taken inside the cell like this. It is taken inside the cell, endocytosis. Then absorbed nutrients will pass to the liver through all these capillaries will join to form the portal vein, and this portal vein drain into the and it will take to the liver, and liver will start metabolizing it. Okay. If there are any harmful substances, it will be detoxified by the liver. So liver will perform purification of this uh, absorbed nutrients. The fat which enter into the lymphatic system, it will not come to the liver. It will directly join the systemic circulation because it is draining into the subclavian vein, then to the heart, and then to the liver after that through the hepatic uh, artery. Okay, so up till now we have seen how the things are absorbed, but what about the amount of water present in the small intestine? The total amount of water in the small intestine is coming from either we drink it or we take it as a in the food, or it may be secreted as saliva, gastric juice, pancreatic juice, or bile or intestinal juice. Total is about, let's say, 9.5 liters. 9.5 liters. Anyway, numbers are not important, just to show you that it is around 9.5 liters, and the volume absorbed by the intestine is 9 liters. So what remains is only 0.5 liter will go to the large intestine. Out of this zero point 0.5, the large intestine will absorb 350 ml. So what is remaining is 150 ml of water, which is lost in the feces. Why we have to know? Because we know that very little amount of water is lost, but if the person suffer from diarrhea, then it will lose more water. So passage of high fluid fecal matter is known as, often with increased frequency of defecation, is known as diarrhea. Is the definition of diarrhea. Diarrhea can be beneficial in some cases because it will remove the harmful materials. If suppose we have taken some food which is toxic or having bacteria inside, then it will cause diarrhea so that it will be quickly removed from the body. But it can lead to dehydration. It can lead to dehydration, loss of extra fluid. Normally 150 ml should go. If it is becoming 500 ml, then it will cause dehydration. Causes of diarrhea are increased motility coming from irritation of the intestinal mucosa, either due to bacterial, viral infection, or it could be due to presence of osmotically active particles such as lactase. As we have seen in the previous lecture, that undigested lactose can lead to diarrhea because it is like a osmol which will carry the water along with it. Also, some toxins can lead to diarrhea. This is the toxin released by the Vibrio cholerae. One disease which is known as celiac disease, or also known as gluten enteropathy. What is this? It is a type of malabsorption. Normally, it has the intestine functions as digestion and absorption. If the absorption is not proper, we say malabsorption. Why it occurs? It occurs because normally there are folds, villi. If these villi are lost, if suppose it becomes a clean plain surface, then the surface area is decreased. This will lead to decreased absorption or malabsorption. One of the condition which is causing this loss of villi is gluten enteropathy, which is nothing but a sensitive immunological disease where it becomes sensitive to gluten. The mucosa will become sensitive to gluten, which is a type of protein. Gluten is a protein which is present in wheat, barley, and rye. This is commonly present here. So those persons which are sensitive to gluten, they will have this condition that here there will be T cell accumulation and something like inflammatory reaction will take place, and after that it will become flat. After that it will become flat. So the absorption of various material will be decreased. Maybe you will have decreased absorption of vitamins, decreased absorption of calcium, decreased absorption of protein, nutrients, all. So what you will do? How will you treat this patient? Celiac disease. Hmm.
Gluten-free food.
Gluten-free food, yes. Any food which is having gluten, the labels are there that is without gluten. So you have to advise that please don't take gluten, don't take wheat, rice, or wheat, barley, or rye. Take only gluten-free items so that there will be no reaction and there will be all the surface area will remain intact. But suppose, what is the other treatment? What other treatment you can do? Avoid the food is okay. Then any other way to treat?
Supplements.
Supplements, very good. You have to give vitamin supplements and nutrient and protein supplements. Oh, good. And any other? You can suppress the immune response. Immunosuppressive agents can be given, right? Desensitization. The person becomes desensitized and can be treated. So for any of the clinical condition, which book you will use?
Amber.
You have, yes, you have to check this topic on AMBUS because all clinical conditions are described, pathophysiology, the signs and symptom and treatment, everything is described there. So for jaundice from the liver topic, previous topic is lactose intolerance also. What are the uh, investigation, and for celiac disease also you have to use AMBUS. Okay.
Inshallah.
Any question? You did not understand anything in this class?
Everything is clear. Thank you.
Welcome. So
Thank you,
stop.
doctor.
Welcome, welcome. Before I leave, let me take the attendance. Very few are present.